behalf of MQR, I, Dr. Preeti Gazwe, welcome you to all in the International Speaker Symposium. For today's meeting, we have Dr. Daniel Coyne, sir, for this global perspective on this use of the sucropheric oxyhydroxide and the hyperphosphatemia CKD. For today's meeting, we have a moderator, Dr. P.P. Verma, sir. Sir is a chairman and Department of Nephrology, Venkateshwar Hospital, New Delhi. Served in Indian Army of over 37 years. He is a DM and DNB teacher and examiner for over 2 decades. Over 300 presentations, then 17 publications, then 15 international publications and 15 books chapters, and 15 chapters in books. Sir was an honorary surgeon to President of India from 2013 to 2015. Then a chief consultant for Indian Armed Forces from 2013 to 2015. Sir, his award is the Ati Visishta Seva Medal, then Sena Medal, and Visishta Seva Medal by the President of India. So it's a DNB Alumnus Award 2014, then Dronacharya Award 2018, and then Camero Quinto Oration 2016, then the Ratnavelu API Oration 2019, and AP Devan Oration, and the annual Renal Nutrition Conference, etc. So started the renal transplantation program at CH Pune, CH Kolkata, and the Venkateshwar Hospital and the Primus Hospital, New Delhi. So with this introduction, I would like to hand over the session to P.P. Verma, sir. Over to you, sir.
So you'll have to unmute, sir.
Thank you very much, and good evening, ladies and gentlemen. And it's a pleasure to welcome you all in this international meet on an important topic in India. We call it Dynolta. Today we have got, the session goes like that. We have got a guest talk by Professor Daniel Coyne. He is an authority in the field of phosphate metabolism. Professor Coyne did his residency long back at Emory, and then eventually he did his fellowship in nephrology at Washington University, and he has been faculty in and presently the professor of medicine in the Department of Nephrology at Washington University, and he's in faculty for over 30 years. He has got tremendous aptitude for research, especially in the field of phosphate binders, anemia, and parathyroid. Today, he will be addressing us a talk on this issue only. Following him, we will have a Indian experience from Dr. Devdatta Shafikar. He is again a very senior nephrologist with over 30 years standing. And he will be talking of solo study, the trial which has been done in India. And following that, we have got a panel discussion and Q&A from audience. So the plan is to have the panel discussion. We have got Dr. Sharad Seth, who is a consultant at head nephrology at Kolikaben Hospital, Mumbai. And secondly, we have got a talk from, other panelist is Dr. Avila Srinivas. He is a nephrologist at Ashwini Hospital, Guntur, and he has been past president and secretary of Guntur branch of nephrologists. So I think without wasting time, we come to the main topic, and I'll request Professor Coyne to go ahead and deliver his talk on the newer phosphate binder, which is there, an efficient phosphate binder, a most potent phosphate binder, that is a sucropheric oxyhydroxide. Over to him, Professor Coyne.
Thank you very much. I appreciate the introduction. As mentioned, I'll be discussing the worldwide experience with sucropheric oxyhydroxide. Most of the talk I'll refer to it as SFO. This is really a story about the creation of the most potent phosphate binder we now have available, and how its use actually drives more people getting to phosphate goal and improves partly through potency, but also through better adherence. They have a lower pill burden. As mentioned, I'm a professor of medicine, so I won't review most of this, but I want to point out I have been a consultant to FMC Renal Therapies, which markets this drug in the US. and I was a participant in the phase 3 trial I'll mention, and also I'm an author on several of the real-world experience studies that I'll be showing. So some of the basics, you can't get to good phosphorus control just through binders. There's really a triad of control: adequate dialysis, diet restrictions, and then binders added to that. In the US, about 80 to 90% of people need binders in order to move toward that goal. Despite that, we only have about 45 to 50% of US patients who have phosphorus control. The ideal binder is going to be very potent because that means they need to take less pills and obviously has to be well tolerated. Just a brief mention about phosphate removal with dialysis and why we can't get there alone. So in this particular study, they took a group of dialysis patients and gave them a 5-hour dialysis treatment. They set the serum phosphorus pre to 100%. During dialysis treatments, the phosphate will fall by about 50 to 60%. It'll actually level off and sometimes even starts to go up because the overwhelming majority of phosphate we want to remove is not in the blood. It's actually in cells and it comes out very slowly. So in contrast to, say, creatinine and urea, when you stop dialysis, the phosphorus rebounds and by 8 to 16 hours will be right back up to the exact same value you started the dialysis treatment with. This occurs recurrently. That's why it takes several treatments to really lower somebody's phosphorus. The main driver of why we want to control phosphorus is number one, hyperparathyroidism. It's very difficult to control that if you're not controlling phosphorus. But number two is observational data like this from Block in 2004. So they looked at a very large population of US dialysis patients and compared the mortality rate over time to those who had a goal, were achieving 4 to 5. Even at a level of 5 to 6, after adjusting for demographic factors and multiple other factors like their degree of anemia and albumin and things like that, we see this increasing mortality among people who have higher phosphorus values. And that's part of the reason KDIGO recommends striving toward a, quote, normal phosphorus. The strongest data that we have that control of phosphorus and binders may be valuable is in this study by Isakova and others. They took they looked at a database of over 10,000 patients who started on dialysis in the US. And at some point in the first 90 days, some of these patients were prescribed a phosphate binders and the others were not. Those who were prescribed a binder in the first 90 days had a significantly better survival than those who were not prescribed binders, even if you look at just the subgroup who were getting good phosphorus control. They then did an analysis that is about as good as we can get when it comes to doing observational studies. They did a propensity score. You're essentially trying to find twins in a population who have every characteristic similar except for your index one. And in this case, it was, did they start a phosphate binder within the first 90 days on dialysis, or did they not? And even in this analysis, the phosphate binder arm does better. And for technical reasons, you would have thought actually it would be switched if this was just a mere flaw in the analysis. So consequently, KDIGO recommends diet control, using trends for phosphorus. Ignore an individual value, look at the overall trend over time. Improve the phosphate clearance, and ideally that would be more days, which most of us can't give to our patients. Avoid calcium-based binders, or at least limit their use because of the relationship to promoting vascular calcification. And then diet. Diet is crucial. We don't want to reduce protein load. In fact, it may be better to have a higher protein load. But vegetable-based diets are far better than animal, and using processed foods and additives greatly increases the degree of hyperphosphatemia. So how did sucroferric oxyhydroxide, or SFO, start? Well, iron-based compounds for removing phosphate from industrial water have been used for decades. And these are essentially microparticles that were added to the water. The pH was altered. Initially, it was typically acidified and then neutralized again. But during the acidification, these agents become particularly potent in binding phosphorus. They're virtually insoluble. So what happens is that at the microparticle solid interface with the water, the phosphate can bind covalently and be removed from the source. The broad pH range suggests that these would work excellent in our own bodies because we have such an acid pH in the stomach frequently, but they also continue binding up into the alkaline range. So that's why it was developed. But to achieve approval, you have to get the drug through the FDA or through the European authorities and other government authorities. So a very large international phase 3 trial was performed with SFO compared to sevelamer as a control group. Over 1,000 patients from the US, Europe, and Russia and South Africa were randomized into this trial. They were randomized 2-to-1 to SFO so we could get more experience with the drug. It was an entire year trial. All of these patients had been on dialysis for 4 or more months, and they had to become hyperphosphatemic when you stopped their baseline binder. The characteristics of these patients are shown on this slide, and they're quite similar. About 92% of the patients were hemodialysis, but there were still plenty of PD patients to look at that subgroup. They had been on dialysis an average of about 4 to 4.5 years. So we're not looking at patients who have significant residual renal function. And because of Europe and international use, most of the patients had as their prior binder calcium-based binders at about 65%, whereas about 35% were on sevelamer-based binders. In the US, that ratio was actually flipped, where sevelamer was the most common at the time of this trial. Now, patients at baseline were randomized to either 2 sevelamer with each meal, so 6 per day, or just 2 sucroferric oxyhydroxides per day. So they took 1 with their 2 largest meals. Consequently, at the first analysis, the SFO doesn't quite lower the phosphorus quite as much as the sevelamer, but after dose titration, both groups achieved substantial reduction in the phosphorus over time, and no patient characteristic made any difference in how potent the drug was. Side effects or adverse effects. During the entire course of the trial, 24% of the patients who were randomized to SFO reported at least 1 episode of diarrhea at some point. But only 6% reported it the week they started the drug. And all but 1 patient reported that it was mild or moderate. All of these resolved within 2 weeks, 1 to 2 weeks. And this is confirmed by a study I'm not going to show from Europe, a phase 4 study, where they asked patients every week after they started about diarrhea, about GI side effects. 6% reported diarrhea during the first week on the drug, and all of these episodes resolved within 2 weeks. Discolored feces were reported by 16%. And remember, the iron's going to change everyone's stool black. So remember that the next time you ask someone whether they have melena or not. A positive helps, a negative doesn't mean as much. Nausea was reported in 10% of the patients. And this rate is actually lower than seen in the sevelamer arm of the study, where it was 16%. And that's consistent with studies with sevelamer in the past. So what really jumped out was differences in pill burden. So initially there was this structured difference. Patients starting on SFO got 2 pills a day versus 6. But after titration and over the course of the first 6 months, the difference was still present and dramatic. And over the full 52 weeks, the average dose for the SFO patients was 3.3, and for the sevelamer patients was almost 9. If you look at just the end of the trial, the SFO patients were getting just under 4, and the sevelamer patients were getting about 10 pills per day. Now, the frequent hemodialysis network trial was really interested in looking at the potency of phosphate binders. So they actually created a table based on in vitro phosphate binding of 1,000 milligrams of each of the agents. And compared to SFO, they predicted that sevelamer and ferric citrate would bind about 40%. So it would take about 2.5 of these pills to provide the binding capacity of an SFO. Lanthanum carbonate, which is also a tablet, is a little bit more potent, but still lacks the full potency of SFO. What's fascinating is in repeated trials randomizing patients to these various drugs, this ratio continues to work out to be very similar to what's done seen in vitro. So we also, every time they came in during the phase 3 trial, they got their pills counted to see how adherent they were with taking the medications. And so during the first 24 weeks, 83% of the patients in the SFO arm had actually taken their prescribed dose of medications, as opposed to 77% of the sevelamer treated patients. In the second half of the study, the last 6 months, this ratio actually increased a bit to 86%. Adverse events I'm not going to focus on. None of these were really considered related to the medications, and they're not different between the two arms. So the results we saw on that are actually quite similar to what have been done in other countries. I'll just show this study in Chinese dialysis patients. Now, in this study, they randomized patients to either one SFO with each meal, so 3 pills a day, and then they gave them 3 sevelamer a day. They could and were titrated to phosphorus goal. But as you might expect, you're now giving them a much more potent pill compared to a less potent pill. So you see a big separation in phosphorus reduction that's favoring SFO at even 1 week, 2 weeks, and 4 weeks. With further titration, both agents get to the goal phosphorus they want, which is less than 5.5. But ultimately, over the course of the trial, after titration, in the last 4 weeks, the sevelamer arm needed 9 pills again, and the SFO arm got 3.7. So we see a very similar ratio to what you'd expect in vitro and what we saw in the international study. So this leads to a hypothesis. In the real world, the higher potency of SFO should lead to a lower pill burden in actual clinical use, and actually also lead to more patients achieving phosphorus goal. And then even downstream from that, is that affecting, say, hospitalizations or cardiovascular events? So all real-world studies are basically looking at retrospective databases of what is actually going on in clinical practice. These initial studies looked at hemodialysis patients, but were also extended to PD patients. They focused on people who were adults because that's what the drug was initially approved for. They had to be on a previous binder so we could look at what happens to pill burden. And then they get their first SFO prescription, which has to go to a pharmacy where we can track which drugs they're on. So if you didn't have a prior phosphate binder, they weren't in these initial analyses. Initially, we did these studies, and the biggest problem is not patient dropout, it's patients dropping out of your data set. So if they change a pharmacy, if they don't get a particular interest in something, then that can lead to a problem. Initially, we had 1,000 patients in a data set, and 424 completed that time period. We extended it to 1-year analysis, and then a full 2-year analysis. And the results were that first, who got switched? They were people who were not achieving phosphorus goal overwhelmingly. Only 15% of the patients had a phosphorus of less than 5.5 when the doctor decided they wanted to put them on a different agent, in this case, SFO. Within 4 to 6 months of the switch, the proportion of people at goal jumped up to about double, to about 30% of the patients. And the pill burden went from 8.4 on their old binder to about 4 pills per day for SFO. These are all US patients. We eat a lot of phosphorus in the US. We eat a lot of everything in the US. The PD patients, similar changes were observed in a study I'm not going to show more details on. So we see this same effect. But what about particular agents? Is there a difference between the binders? Well, on control, no. They all were at about 15, 16% of the patients being switched had adequate phosphorus control. And after changing to SFO, this rate doubled approximately. The phosphorus binder pill burden was halved or more with sevelamer, with calcium acetate. And interestingly, with lanthanum, you remember that's the pill that's more potent than sevelamer, but less potent than SFO. The pill burden didn't change, but the proportion of patients at goal got significantly better. This may partly be due to potency, but also due to certain long-term tolerance effects about lanthanum, that it's not as well tolerated. 1-year data looked very similar, except now we're getting about 40% of the patients to goal long-term. That may reflect further titration, because the average dose in the US in this study went up to about 4.4. It was still half of what it was when they were on their prior binders. And here's the binders from that study, looking out 1 year. And then now we're seeing much higher percent of people getting to goal, probably with a little more titration going on, but it doesn't matter which prior binder they were on. And then this is the 2-year data. So each of these bars represents a 3-month period. We'll focus mostly on sevelamer here because it's got the most number of patients. And you can see about 18% were at goal prior to the switch. It immediately jumps up to about 30%. And then over time, it continues to improve. In a population who's getting this drug, largely because they're tough patients to treat. That's why they have such poor phosphorus control. Similar effects were seen with the other drugs, and I won't focus on that. Now, if all that's true, then patients who are prescribed this drug should actually run out of the prescription and need to refill it more often. And in a very nice study done by DaVita, about half the units in the US are Fresenius, another half are DaVita, so they're the competitor. They did this study of their data set using totally different patients in a different pharmacy. And what they found was when they looked at number of pills prescribed, it was running at about 11 binder pills per day. The dotted line is when they were given their first SFO prescription. The total binders that month jumps up because they're switching from one binder to the other. The number of SO pills prescribed was initially about 3 or 4, and then was titrated and the other binder was eliminated. That led again to this jump up in phosphorus control, and then it improved to about 40% by 6 months of monitoring. But what was most important was prescription refill. So they were able to track that on a monthly basis. And at baseline, the overall rate in the previous 6 months for the patients on sevelamer and calcium acetate mostly was 68% of the time they refilled their medications when they should have been at 100%. This rate jumped up so that in the second 6 months on SFO, the refill rate was 80%. And in fact, in the last 2 months, it was actually about 90% of the patients. So all of this fits together really nicely, that the more potency means they take a higher proportion of their pills. They need to refill their medicine more often. But there's a legitimate criticism. All of these patients are serving as their own control. What if we just left them alone? They may have gotten better anyway. So to address that, we did this case control study. We identified a population of patients who in the first 90 days were prescribed SFO. And then we looked at the maintained group were the people who, for the next 2 years, got no other binders and SFO and always got an SFO prescription for management. The other group were those who, for whatever reason, and we are unable to look and find out, stopped the SFO and went on to any other binder, including changing binders, over the next 2 years. How did these two groups do? If it was just because they were going to get better anyway, then these numbers should look the same. And they did not. So prior to the switch, about 18% of people were at goal. The blue bars represent 3-month time periods and those who were maintained on SFO for the full 2 years. The maroon bars reflect those patients who had SFO for some part of that 90 days, but then were taken off of it. And even in the first quarter, the SFO alone arm is doing better and maintains that difference throughout the entire full 2 years. And at the end, the average pill burden was 11 for the patients who discontinued it. This is phosphate binder pills versus 5 for the SFO. Because of that design, we can also look at hospitalizations. And I'll tell you, we looked at subgroups of hospitalizations like cardiac hospitalizations and infections and everything. And we didn't see any difference. Those numbers get much smaller. Total hospitalizations has a lot more numbers, and it's easier to see differences in them. Now, if these two hospitalization rates were the same, then the incident rate ratio would be 1 here. But even adjusting for prior hospitalization rates, we saw that those maintained on SFO were hospitalized at a lower rate over the course of the 2 years than those who discontinued the SFO. And if we look at a stricter definition of hospitalizations, that effect is still there. We can then adjust for other demographic data, like whether they're diabetic or not, how long they've been on dialysis, their age, and many other factors, including laboratory data that we know influences mortality. And the difference actually became more dramatic, which if you look at the longer hospitalizations, there was a 30% less hospitalizations in the individuals who were maintained on SFO compared to those who had tried it and stopped it for whatever reason. So it's important to understand when we prescribe pills, what the patients want is also important, and what their side effects are frequently drive their decisions. All these drugs have situations where patients initially will have GI symptoms related to that particular drug, and all of these modulate with time. So part of it's talking people through it. Calcium and sevelamer tend to be constipating, and so it's important to know if they're having constipation already, if you were to use those. Iron-based binders are going to cause looser stools in general, and this also modulates typically, like as I pointed out, a small fraction have diarrhea, and this resolves within 2 weeks. It will also turn the stools black, so it's important to notify the patients about that. Calcium uniquely can cause hypercalcemia and should obviously be monitored steadily. And sevelamer can also cause bloating. It's a polymer that expands, so when they take a lot of pills, as some of the patients were in the study, the max dose in those trials was 18 pills per day. They can get significant expansion in their stomach and feel very bloated, and it can affect their intake. So in summary, KDIGO recommends, and it really is coming out of practicality and science, we need to control the dietary intake of phosphorus and move more toward vegetable-based sources is always the best. Adequate dialysis clearance. Longer treatments help a little bit. High flux helps a little bit. Ultimately, more days on dialysis would help the most. And then use binders, preferably non-calcium-based binders. The ideal binder is going to be potent. They don't have to take too many pills. Their GI side effects are well tolerated. And right now, SFO fills that bill. And the real world data shows what we predicted from the potency really has turned into clinical improvements. So thank you for your time. I'll stop right there and stop sharing. So thank you for your attention.
Thank you very much, Professor Kine. It was a masterly lecture.
Thank
I
you.
must compliment you because you touched on all the three phase 3 trial, then you touched on the real world experience, then you also commented on the Chinese study which was there, and all the trials you have clearly shown that one, can we just keep it down? Can we talk to Professor Kine?
Yes, I'm here.
Yeah, because the major things you told us that one, the response rate is almost double of then if you are using other phosphate binders. The pill burden logically is 1/3 to 40%. The compliance certainly is excellent, better compliance than any other phosphate binder. And you also touched on possibly lower hospitalization rate, almost by 30% in these patients. I think we will have more of comments from you when we have panel discussion. But once again, I thank you for your masterly oration. Thank you, Professor Kai.
Thank you.
Now we move on before we have the question answers to an Indian study, what we call the solo CKD study. This was the study on the same sucroferric oxyhydroxide monotherapy for hyperphosphatemia in Indian CKD patients. This is, people are still carrying on with the study. This was done in 3 or 4 centers. And I'll request Professor Shafikar to give a brief overview of this study. As I understand, this was a 12-week trial with the drug. And what was the result and inference? I'll request Professor Shafikar. Over to you, Professor Shafikar.
Good evening, everybody. And in brief, I'm going to tell you about the solo CKD study, which is the Indian experience as far as sucroferric oxyhydroxide is concerned. And Dr. Verma has already very well summarized Dr. Daniel's talk. And let's look at the Indian experience. So this is the first real world evidence of SFO, which is called Dynelta in the Indian patients. And it is basically a monotherapy in patients of CKD undergoing hemodialysis. It's a phase 4 single-arm open-label study. And it enrolled around 114 Indian patients who had hyperphosphatemia. They were on dialysis, and the primary endpoint was change, of course, the change in serum phosphorus at baseline to week 12. That means after a period of 3 months. And the secondary endpoints we looked at were the adverse events, as well as some biochemical parameters in the form of the liver enzyme, glucose, calcium, and of course the PTH at week 12. So the inclusion criteria in brief were that hemodialysis patients who were at least taking hemodialysis for at least 12 weeks prior to screening were included in the study. And the diagnosis of hyperphosphatemia was defined as a phosphorus level more than 5.5 milligrams per deciliter at the time of screening. And of course, they gave a written informed consent as far as the population is concerned. Patient who had GI issues or active GI disorders or hepatic disorders were excluded from inclusion in the study. And of course, if they had dysphagia, swallowing difficulties, or if the life expectancy was poor or anticipated renal transplant, again, they were excluded. If the patient had a raised ALT and AST levels more than the upper limit of normal, or if the serum calcium was more than 10.5 and the IPTH was more than 800 nanograms at the time of screening, again, that population was also excluded. And of course, the pregnant patients were also excluded. So the methodology was that they had a screening period at the time of the first visit. They took the medical history and looked at the inclusion and exclusion criteria and took the informed consent. Post that, after applying the exclusion criteria, then they included the patient in the study. On the first day of the visit after having done the necessary vital signs and physical examination, a standardized diet was explained to the patient with the help of a dietitian, because diet is a very important part to control the hyperphosphatemia. And then the subjects were told to maintain a diary. The second visit was at day 28, and the third visit was day 56. And again, what was assessed was physical examination, review of the diary of the patient, the frequency of dialysis, adequacy of dialysis, concomitant medications, and assessment of serum
Mr.
phosphorus
Shaplikar,
levels.
can you make it full screen? It will be better.
Yeah. So what was done was that in the second visit, a follow-up visit at day 28 and 56, they looked at all these parameters, including the dialysis adequacy, concomitant medications, and the assessment of serum phosphorus levels at both day 28 and day 56. And we know that the study period was around 3 months. So at day 84, plus or minus 2 days, that was the end of the study visit. And again, they looked at the data as far as the diary entries are concerned, medication compliance, diet compliance, as well as they looked at the biochemical parameters, which we have already seen, which included serum calcium, phosphorus, PTH, and of course, they also looked at the adverse events and concomitant medications. So the standard demographic characteristics are shown here. Total number of patients enrolled were 114. The mean age was around 50 years. Males and females were almost equal. And of course, this is an Indian patient study. And the other parameters are there for you to see. Let's go on to the results immediately. And the primary endpoint, which was basically a reduction in the serum phosphorus level, we know that 114 patients were actually screened and they met the inclusion criteria. But out of these, 94 patients completed the entire study. And here you can see what is the change in serum phosphorus level during each visit in the subsequent follow-up. And therefore, at the time of screening visit, the mean phosphorus value was 7.62 milligrams. And at day 28, it had reduced to 6.37, day 56, 5.49, and day 84, 5.13, indicating there was a significant fall in the serum phosphorus levels, which was also applied statistically. So this was the primary endpoint. The number of patients at day 28, which is the second visit, the number of patients who achieved the serum phosphorus less than 5.5 was around 37, and that's about 39%. At the third visit, which is day 56, the number of patients who achieved serum phosphorus less than 5.5 milligrams jumped to 53.19% of patients. And at the last visit, that means the visit number 4 at day 84, the number of patients who achieved the target of serum phosphorus less than 5.5 jumped up to almost 65.9%. As far as the secondary endpoints were concerned, they also looked at the adverse events, and the treatment emergent adverse events were also looked at. For example, the noted adverse events were so-called adverse events were pyrexia, headache, pain, rhinorrhea, diarrhea, cough, dysentery, edema, etc., and vomiting. And none of these subjects were discontinued because the adverse events were not very significant. And these are the other laboratory parameters which were studied during the study. So they looked at the serum calcium, the intact PTH, which are of more interest in patients of CKD-MBD. The calcium levels were well maintained, and the PTH, there was not much of a significant change. There was some drop in PTH levels at the day 84, but not statistically significant. And the other parameters related to hemoglobin, hematocrit, SGOT, SGPT, and glucose were largely unaffected and not indicating any change. So to summarize the results of this real-world data, which is in the Indian population who underwent hemodialysis, is this. Almost 65.9% of patients achieved a serum phosphorus level, which was the less than 5.5 milligrams targeted at week 12. 28.9% of patients went lower than that, that means the phosphorus levels were less than 4.5 at week 12. So indicating that this is a very highly potent and effective phosphate binder in the Indian population which was studied. And there were no safety concerns as far as the drug was concerned. And there were no changes observed in the biochemical profile as well as some clinical parameters. And therefore, there was no discontinuation as far as the study population was concerned, no discontinuation of the drug. So to conclude, the Indian data published in the World Journal of Nephrology this year, this study demonstrated the efficacy of SFO in reducing serum phosphorus levels in Indian patients of chronic kidney disease on hemodialysis. The molecule was well tolerated and was found to be safe in the Indian patients. And therefore, if one uses sucroferric oxyhydroxide as a monotherapy in the hemodialysis population, it is very effective treatment option, and the advantages of SFO has already been enumerated in the previous talk, and definitely it reduces the pill burden. So therefore, from the Indian perspective, this was a good study, which is a real world evidence as far as use of SFO is concerned, showing its effectivity and showing the benefits as far as SFO is concerned. Over to you, Dr. Varma.
Thank you. Thank you very much, Dr. Shafikar, for clearly bringing out what the data, Indian data is. But don't you think the response rate is fantastic? Over 12 weeks, you showed a response rate of almost over 60%. Yeah,
Yes. So
30% initially. Do you think this response rate is even better than the Western world data?
it seems so, but of course, you should look at the initial phosphorus levels, which were not very high in our patients. Maybe in the Western population, the initial phosphorus levels at the beginning of treatment are slightly higher, and therefore the time taken to bring down the serum phosphorus is more. But as far as our patients are concerned, if you look at the initial serum phosphorus levels, it's about 6.7. So therefore, to achieve the target may not be very difficult.
Thank you very much. I think I'll request the other panelists also, Dr. Sharad Seth and Dr. Srinivas, both are here. Let's have some discussion on hyperphosphatemia and this molecule. First question, I'll put it to Dr. Sharad Seth. What do you feel in Indian scenario? What is the prevalence of hyperphosphatemia, especially in dialysis population, are stage 4 or 5 CKD? Dr. Sharad Seth. You are muted. I think you will have to unmute. Hello. Dr. Sharad Seth is muted. So I'll request Dr. Srinivas to give his.
Yes, sir.
Hello, am I
Yeah.
audible?
Yeah, you are. You are audible.
Ah, wonderful. Almost 90% of stage 5 CKD have hyperphosphatemia more than 5.5.
And what about the CKD? I mean, those was a very varied field, but stage 4 or 5, before they come on dialysis, how common is hyperphosphatemia?
It the hyperphosphatemia sets in from stage 3. Before that, because of high FGF23 and PTH, tries to maintain phosphorus near normal level. But beyond stage 3, the hyperphosphatemia is evident, and we need to treat even before they reach the stage of dialysis, hyperphosphatemia, because the observational studies have shown that there is increased mortality, cardiovascular mortality with hyperphosphatemia in CKD patients.
I'll just put the question to Dr. Srinivas. What do you feel about the dietary aspect in different parts of India? Some people are non-veg, Some people are vegetarian. We all know that the plant diet absorption of phosphorus is less, so possibly it should be less. But your comment on that.
Yeah, definitely diet plays a major role. And predominantly, despite we say non-veg, our food consumption is predominantly vegetarian. And as compared to the Western this thing, the vegetarians have less phosphorus or serum phosphate levels. Absorption is less. So relatively, that's one of the reason probably that our phosphorus levels may not be as high as in the Western
In
population.
your dialysis population, what will be the average phosphorus level you see?
It varies around 7 to 9
Oh,
in
7 to 9.
untreated patients when we start them on
Okay.
initially.
I'll put it to Professor Cohen that Western world with the prevalence of taking processed food, plus you are having a lot of non-veg food. What is the prevalence there in dialysis population?
Well, we treat so early, so most of the patients, as soon as we start seeing certainly 2 phosphorus values in a row above 5.5, they usually get started on a binder, and sometimes even when they're in the low fives. So in the trials, like the phase 3 study, where we stopped the binder for a month intentionally, the average phosphorus jumps up to 7.5 within 4 weeks. And it undoubtedly would have been significantly higher if we waited out even more.
Dr. Shafikar, your comment on this.
So I feel
Rather,
that
I'll ask you, at what level of phosphorus, what is your threshold? When do you start phosphate binders?
Yeah.
Now, Kedoki does mention that if consistently phosphorus level is high, what definition you follow that consistently it is high?
So two things. One is that the incidence of hyperphosphatemia in our population is slightly lesser as compared to the Western world, because we have a lot of malnourishment and a lot of protein related issues. That is one thing. And the second thing is that the diet, which is already mentioned. As far as the level of phosphorus is concerned, in our practice, we should differentiate between the non-dialysis population and the dialysis population. So in the non-dialysis population, again, we are seeing a level of phosphorus which is up to more than 5.5 milligrams. And that is the threshold at which, in fact, we should start treating even in the non-dialysis population. But as far as the dialysis population is concerned, the incidence of hyperphosphatemia is slightly higher as compared to the non-dialysis population. And there we are seeing an average of 6.5 to 7. And of course, in that population also, we should be very aggressive in treatment. So I would like to differentiate between the non-dialysis and the dialysis population as far as the initial diagnosis of hyperphosphatemia and the threshold for treatment.
But you said your threshold is 5.5. If it is so, you start phosphate binder, other measures to reduce the phosphorus. Professor Cohen, what is your take threshold? You are a master, I think. People
Well,
have to go by your word. Yeah.
So, I like to try and take a global look at this, and ask, why are we treating the phosphorus? And while the cardiovascular things remain unproven because we don't have trials, we know indisputably from pathophysiology that it's one of the triad of issues driving hyperparathyroidism. And long term, if we ignore it, we're going to have really bad hyperparathyroidism in people. So I think in our dialysis population, we certainly want to treat when it's above 5.5, but we also treat when it's generally above 5, because again, the goal, and KDIGO would say, you want to keep it normal. If you do keep it normal, there's much less pressure for higher PTH. In the non-dialysis population, in the US, it's very controversial because no phosphate binders are approved for use to treat hyperphosphatemia in non-dialysis patients. That's because of the FDA. But off-label, my logic is the same. If their PTH is elevated, certainly above 100, I'm way more interested in getting their phosphorus binder going and getting that under control. And so generally, if they're above 4.5, I'm going to probably start them on a phosphate binder, especially if I've seen serial values that are above 4.5.
Okay, I think that's fine. Dr. Seth and Dr. Srinivas, any comment? I possibly go maybe little late, minimum 5.5 or above. But as you said, you start treating at 4.5 also or 5 also. Any comment, anything, your opinions, Dr. Seth and Dr. Srinivas?
Yeah, I think the latest observational studies have shown no additional cardiovascular mortality benefits of strictly controlling phosphorus by giving phosphorus binders beyond 4.5. So I agree with Dr. Shafekar. If it is 5.5 in non-dialysis, I think that is the threshold for which we should start phosphorus binders. Below that, the studies have not shown any evidence has not shown any mortality benefits.
How often you are measuring phosphorus in non-dialysis and dialysis patients?
3 monthly, 3
3
monthly.
months. Dr. Srinivas, you- hello. Yeah, you are not audible, Dr. Srinivas.
Yeah, we measure phosphorus, but rather than the measurements, the serum PTH and other things, like we don't go strictly by the book. Depending on the patient's symptoms, what we see clearly is the patients whom come with pruritus, which is a common complication of the phosphate and calcium metabolism defects. When we start these patients on SFO, rather than using ointments and all other preparations, when the phosphorus levels come down and the calcium based phosphate binders are reduced, they show remarkable improvement, and within few weeks the pruritus is resolved. This is one of the clinical findings which I've seen
Okay.
throughout my
Dr. Shafekar, let's come to the molecule we are discussing today. What is your phosphate binder of choice? We all know that initially we all used to give calcium-based phosphate binders. I personally feel in India the use of calcium-based phosphate binders, which is a recommendation from KDIGO also, has significantly gone down. Possibly we are using maybe 20-25%. The maximum patients are on calcium-based. Rest are on possibly Sibalimer. Majority. Your opinion?
So I agree with you that the use of calcium acetate is definitely going down in our population for many reasons. And of course, till the availability of SFO, majority of our patients were on Sevelamer in the right dose. But when we saw the tolerability of Sevelamer and the pill burden, and with the advent of SFO, there are three situations where SFO can still be considered. One is the primary monotherapy, as mentioned in the Western data as well as the Indian study which was presented. Then it can be a switch therapy in patients who
I
are
fully
already.
agree. To make it brief, where do you place sucroferric oxide?
So
Do you
looking at
use it as a primary therapy as a phosphate binder? Or you are using it as a substitute once you stop it and start this? Or third is addition to whatever you are giving?
yeah. So the first two situations are true, where we are using it as monotherapy right from the word go. And how I think about it is like this. If the serum phosphorus level is pretty high, and we know the effectivity of the molecule and the low pill burden, I would prefer SFO when the serum phosphorus is very, very high, say more than 6.5. But if the serum phosphorus is not that high, then we can consider initially Sevelamer and then we can switch over also. So initially, depending on the serum phosphorus level, I would like to go for monotherapy of SFO right from the beginning. And if the patient is not tolerating Sevelamer, then I would like to switch.
I think I tend to really agree with you on that score, that is the philosophy we also adopt, that if the phosphorus level is pretty high, 7.5, 8 or something. And you know that efficacy-wise, Professor Coyne clearly showed that we in India say that 1 gram of sucroferric oxide tablet binds something like 260 milligram of phosphorus. Vis-a-vis, if you take the Sivalimer, possibly it is in 30 or 40. So it is significantly higher. So logically, if the phosphorus level is pretty high, I'll choose sucroferric oxide as a SFO as a first molecule. Dr. Khan, if forget it about the Medicare or insurance company gives or not, but scientifically, if you have to choose, which one you choose?
Well, I'm gonna use it. Same thing as treating hypertension. Less is better if it can get you to goals. So I'm gonna use SFO in patients whose insurance can cover that, because they're going to have less pills to take every single day, and I know that's going to improve the outcomes. It's like putting somebody on a 3 times a day antihypertensive versus a once a day. It's a no-brainer.
Yeah. Uh, Dr. Srinivas, because you also must be having a large experience with SFO, do the side effects really bother you or bother your patients?
Not much. The side effects really, in fact, they are useful side effects. Most of the patients, our patients on hemodialysis, have constipation, and using this, which increases the GI motility, iron-based products, they are useful. And very few patients I really found that they complain that they have diarrhea or black feces. If we tell them at the start itself that they are going to have this black feces, then that's not a problem.
Yeah.
And in addition, there is some amount of iron absorption and reduction in the erythropoietin doses also, which we found.
Because the literature says that iron absorption is practically nil or negligible.
I personal experience is that they require less IV iron and less erythropoietin in this group of patients. Maybe the studies may not be much.
Yeah, right. No, that's interesting. That's important.
Yeah.
Dr. Seth, your comment.
No, I totally agree with Dr. Srinivas. Most of the CKD patients are constipated, and the diarrhea is not an issue. And we need to inform them beforehand that they will have black stools. So the side effect is not an issue. And as you rightly said, the phosphorus binding capacity. See, it's a ligand exchange between hydroxyl and phosphorus. The iron is in tremendous thirst for phosphorus binding. The phosphorus binding capacity of iron is 35 times more than hydroxyl. So the phosphorus binding is excellent. Iron is hardly absorbed. That is benefit of against ferric citrate. And I see that the 2/3, as you say, that if a person normally takes around 7,000 phosphorus per week, and the burden 4,200 is the burden of which 1,800 gets. So it comes around 257 per day. And as you, Dr. Verma, you said that this 1 gram of sucroferric oxyhydroxide removes 260 of phosphorus. It's ideal. 500 milligram twice a day is excellent.
Professor Kain, your comment on one or two issues what came up. One is that do you really, in your studies, do you find that is there any significant iron absorption?
There, in the
I
phase,
don't see. The
in the
ferric citrate came, the molecule went
I
out of favor
Ferric
because of
citrate,
iron
yes.
absorption.
Yeah, ferric citrate, yes.
Yeah, ferric citrate. Ferric citrate.
Their absorption is there. There the ferritin level goes up. No, I'm asking Professor Kain
Yes.
about the SFO.
Yeah. This was carefully studied in the phase 3 trial, among other studies, in in addition to a specific study looking at it. Compared to the sevelamer arm, both arms had an increase in ferritin, but that's because in the U.S. There was a shift in payment, and so iron became more heavily used in both arms. So ferritin went up actually insignificantly different over the entire year. So that indicates very little difference in iron absorption. TSAT did statistically significant increase in the SFO arm compared to the sevelamer, but we're really only talking about a 2% higher value. They also looked at ESA needs. They were not significantly different between the two arms over the course of the study. And, one of my other hats is an expert in iron and anemia in dialysis and CKD patients. And so I can say there probably is a milligram or 2 or 3 of iron that's absorbed with this product versus, say, being on sevelamer, which has no iron. Over the course of the year, it's not making a big difference. It's not going to get people iron overloaded. And depending on the diet, and as mentioned by one of the other speakers, he saw a reduction in IV iron needs. That's certainly possible if individuals are not matching the binder with their food or have far less phosphorus that needs to be bound, and so maybe a little bit of iron is being absorbed in those people.
I think we have discussed today most of the issues that we wanted to talk about SFA. First, we said hyperphosphatemia is a burden, big burden in patients, especially on dialysis. And hyperphosphatemia is strongly a risk factor. There are different phosphate binders to reduce it, but once we come to the efficacy-wise, the studies, Dr. Khan has shown that the efficacy-wise, it is almost double the efficacy than other phosphate binders. That's important. Logically, the pill burden is very, very significant. Almost 1/3 of the pill burden is there. If you are using SFO, the side effect is not an issue. Compliance is certainly much better. He has clearly shown that even after 6 months to 1 year, 83% compliance, which is excellent. So I don't think there is any doubt that SFO remains a treatment of choice, should be. And there may be a question in some areas where it may not be getting covered by insurance, or the cost may be little more. But if we talk science and remove the cost factor, possibly SFO will win all. Hands up, hands down, SFO is great. Dr. Shafikar, last comment, and then our time is over. Then we can.
Two quick things I wanted to say. I wanted to know from Professor Daniel two things. One is that in our practice, I've seen some patients where I had to combine sevelamer along with SFO, whether they do it there. And secondly, why is it off-label in the non-dialysis?
So in the combining drugs was actually studied in real-world data. Don Maloney has a paper out on that. Adding in the SFO to the other binders, just as in the SFO alone real-world data I showed you, improves mean phosphate control significantly. You see this big jump in a number of people at goal, and then it continues over time. But the total pill burden is now much higher. And even though they titrate down on the sevelamer, at the end of the day, those people were taking an average of 10 pills a day. And, for some patients, that's what they want. They like playing around with that. That's fine. They're the focused patients that I don't worry about. In the non-dialysis population, the FDA does not consider hyperphosphatemia a disease in non-dialysis patients. And so consequently, they will not approve it unless a trial is done to show some clinical endpoint like mortality or cardiovascular changes or severe hyperparathyroidism is prevented. That would take hundreds and thousands of patients over long periods, and nobody's willing to do that.
Thank you very much. Thank you very much, Professor.
Dr. Verma, can I ask a question to Dr. Coyne?
Please, last question.
And the protein-bound uremic toxins, pre-cressyl sulfate and indoxyl sulfate, does it have any additional benefit of SFO to bind this the protein-bound uremic toxins, indoxyl sulfate and pre-cressyl sulfate?
Well, now you're really testing me. So years ago, I was involved in a chromesin study, which is a binder that bound those two particular agents, and it was a very well done study in the U.S. Patients were randomized to either a placebo or that drug that they took 3 times a day. I will say it doesn't make a difference, because in that trial they got significant reductions in indoxyl sulfate levels, and it showed no clinical slowing of progressive renal failure. So, you know, SFO is not targeted at doing that. It may lower the levels to an extent, but if a drug intended to do that didn't have a beneficial effect on progression, it's hard for me to say SFO would.
Because that's the main driver of IFTA, interstitial fibrosis, tubular atrophy.
Yeah.
Leave aside.
So it may be that chromesin years ago, you need to lower it even more. And so maybe combos would get there, but you know, the science I don't think supports that it necessarily would make a difference with SFO.
Thank you very much.
Very much, Professor Cohen. And keep in mind that over 200 nephrologists, when we started the session, they were already logged in. And I think they must be very happy to listen to Dr. Professor Daniel, that the clear concepts that what the standing of SFO molecule is. And logically, we all panelists, irrespective of whichever session we are attending, we all have been using SFO liberally. And that gives a further strength to your statements that it should be used as a primary therapy rather than many times add-on or substitution. One should go as a primary therapy and get the benefit of better potency and less pill burden. I think with that, we will stop here. And I thank Professor Kain and all the panelists, Professor Trafficker, Dr. Srinivas, Dr. Seth, for making this session very fruitful and knowledgeable. Thank you very much.
Thank you so much, sir, for the excellent presentation and excellent panel discussion. I would like to invite Ravikant, sir, for the vote of thanks. He's a Director of Sales and Marketing, Dialysis and Transplant Division. So over to you, Ravikant, sir.
Thank you so much, Preeti. And firstly, thank you so much, Professor Daniel, to be with us in this evening, sharing the global perspective of SFO and also enlightening us on various aspects on SFO. Thank you so much, sir.
Thank you.
Again, thank you so much, Dr. P.P. Verma. You have been a guiding force to us
Thank you very much.
in many things, you know, to establish the right optimal treatment of hyperphosphatemia in the country. I think, you know, thank you so much again for chairing this session and being with us. And we had almost 300 plus nephrologists in the country listening to the entire discussion. I think I'm pretty sure it'll help a lot of them in managing their patients much more efficiently. And also Dr. Chafrekar for presenting the solo CKD study. Thank you so much, sir. And again, for presenting it and also bringing the aspects of the study on the forefront. And I also like to thank Dr. Sharat Sheth and Dr. Awul Srinivasrao for being on the panel and getting the discussion much more meaningful and also helping the physicians in the country for better management of hyperphosphatemia. So once again, thank you so much, sir, for being with us in this evening, and we truly value it. And you know, we look forward for much more sessions on different topics which can help the Indian nephrologist on various managements of nephrology. Thank you so much, and deeply appreciate it. Thank you so much.
Thank you. Thank you. Thank you.
Goodbye.
Thank you.
Thank you.
Thank you, everyone.